So I'll just do a brief introduction of Dr. Kibuuka, who is a resident implantologist, currently working in the US in the University of Loma Linda in
Can you see my
California.
slides? Oh, no.
No, they were there earlier.
Okay. Let me see.
Okay. So, like I was saying, Dr. Ham is a resident implantologist at the University of Loma Linda, where he's pursuing his fellowship in implantology. And a few of us know him, a few of us have seen him. So he's worked in Uganda, he's worked with a few places. I think it was Victoria University, former Victoria University Dental Hospital at Nakasero Dental Hospital, did his internship here. I think he was in my lot and has worked in Kenya for some time as an implant specialist and consultant, general dentist then. But now he's at Loma Linda pursuing his master's in dentistry, where he's going to be looking at implantology. That's where he's specializing. And we're going to hear from him what he has to offer to us when it comes to implantology, the bad, the good, and the ugly. So, Dr. Kibuuka, I don't know if I did you justice, but in case I've missed out anything, please go ahead. And the floor is all yours.
That was perfect. Can you see my slide now?
Yes. You're good to go.
You can? Okay.
Yeah.
Good.
Yeah, perfect.
All right. No, thank you so much, Dr. Kizito. And like you mentioned, my name is Dr. Ham Kibuuka, and it's just on a side note, it's very interesting to actually say your name and everyone understands what you're saying. Whereas here you have to say Kibuuka and that messes up everything. But I'm very happy and excited and humbled to be speaking for the group this evening. Like you said, I've been to Uganda, not to Uganda, I'm Ugandan, and I worked in Uganda for a bit. I worked in Kenya for a bit, then came to the school, to Loma Linda University School of Dentistry. I'm in the advanced education program for implant dentistry. It's a 3-year program, and I am in my 3rd year, about to finish. Plan is to graduate in May next year, and then June I should be finished. And again, just thank you for everyone who's present. I'll go straight into the presentation, and in case anyone has any problem, they can't see or anything like that, please let me know. But I shall start. So today we're talking about dental implants, the good, the bad, and the ugly. And I'll go through a brief history of what implants are. Most of us already know what they are. Okay. Most of us know what dental implants are, but I'll just go through them a bit in terms of materials, how they work, and then we'll proceed on. So dental implants, most of them, the ones on the market that we have right now, are made out of titanium. A large number of them are made out of titanium, and the different surfaces different surfaces on those types of titanium implants and things like that, or the majority of them are titanium, and we are getting we're getting to an era where now we're getting zirconia implants, and this is zirconia implants are good. We know the properties of zirconia, why people are trying to incorporate zirconia as into implants. We have holistic patients who mention that they don't want metals in their mouth, even though zirconia is from zirconium, which is a metal, but still we'll not get into all that. But the majority of our implants these days are titanium. So in fact, let me just go back. The reason why zirconia implants, they might be good. Of course, the placement and things like that for zirconia implants is a bit different, but they also have their limitations. One main limitation is the fact that you can do full arch on zirconia implants. Now, the 3 popular implant surfaces out there There might be more, but the most common, most popular are the anodized surface, which is popular with the Nobel Biocare implants. Fluoride surface, which is popular for the Astro, and I think Astro now is under Dentsply Sirona. Then the airborne particle abrasion surface on implants, which is the Stroman group, and that is a photograph of the surfaces. And when we start talking about the osseointegration, we have to talk about the titanium oxide layer that forms, and that's what actually aids in the osseointegration of the implant. Okay. So the oxide becomes coated with the blood-derived proteins, and when the implant is placed, and they later on, and with that whole process, that's how you get in osseointegration of the implant, and you get the incorporation of bone around that implant. Now the term, hello, sorry. Oh.
No, sorry.
Now
Go
the
ahead.
term.
It was a sentence.
Okay. Now the term osseointegration it was derived or came about by who we consider the father of implants. His name was Dr. Brandemark, back in, I think, the 60s, and he's the one who coined the term osseointegration. And implants at that time, when they were first developed, they were mainly for full arch cases, mandibular, for the mandible actually. And there were machine surface, you were placed parallel, you put a couple inside, maybe six or so, and that's how implants came about. He did, in fact, when for integration, when they're doing their research back in the day, they just put a titanium rod into a rabbit, and so that there was actually bone that was forming around it, and that's how implants came to be. He subsequently, as time went on, people started saying, "Oh, can these implants be used in other places, or do they have other functions or uses in dentistry?" And that's how we started using them for missing teeth, for example, anterior implants for fixed dental prosthesis, FPDs, FTPs. Implants went from machine surface to the coated implants that we have right now. They went from tapered to they went from parallel implants. They went to tapered implants. They went from bone level implants to they went from tissue level implants to bone level implants, and that is the first figure that you see up there. Most, in fact, Straumann was known and is known for good bone tissue level implants. They still have them, and they have the indications, for example, in the posterior of the mandible, where you are fighting in space, where you're not too worried about aesthetics. Tissue level implant is a good option. But if you are now considering or thinking of placing an implant in the anterior region, if aesthetics is one of the chief concerns of the patient, you can definitely not put a tissue level implant. You have to put a bone level implant. If you're also fighting for space, especially in the anterior, a parallel implant will not be the most ideal to put. It's been done before, and they can still do it. But that's where we get the tapered implants that are placed in that area, and they give you more leeway, and you can better place the implant and the prosthesis later on. So on the top figure there, you see different types of the implants. For example, the tissue level, like I mentioned, the bone level. Then you move on to the lower right figure here. The implant itself is an artificial anchor. When I'm explaining to my patients, I tell them it's an artificial, it's like a screw, and that is layman's terms. It's like a screw. You need something to hold into, like when you're putting a painting, you need some stability in the wall. You put an implant in it to give you that stability that you need for the crown that you're going to put later on, the denture that you're going to put on later on, the bridge. Now, what connects the prosthesis to the implant is the abutment. You have different types of abutments, there are different connections, and I'll just briefly go through those as well. Like I said today, every topic in implant you can spend a whole hour, but I'll just briefly go through just a few. So, for example, the abutments that we use, you can either have the platform matching, like you see on the lower right, most right diagram here, platform matching and then platform switching. And now the way that abutment connects to the implant can also differ most back in the day we used to have external hex connections. Nowadays we have more of the internal hex connection of into the implant. And a fun fact about the platform switching, there's a type of implant called the 3i implant that was developed, and they were the first to actually come up with wide platform implants. They came up with the 5, 6, and things like that. And when they were coming up with wide platform implants, when the one of the company was trying to restore that implant, he didn't have the apartment that matched, because back then it was a platform matching that matched that implant. He ended up using a smaller apartment, then later on being known as the platform switching, and they noticed that there was some kind of bone growth on top of the implant, and that's how that concept came about. And that's how we have platform switching, because when you do platform switching, you are able to sink the implant a bit more subcostal, for example. They say that it's better for the tissue. The reports that say that it reduces preimplantitis. But that's where we are right now. And now, still continuing on with the abutments and connections. The figure on the top left there talks about the crown, the abutment, the screw, and the fixture. We are now also living in the era where initially implants, the abutment was connected to the implant. Cement was basically placed into the abutment was screwed onto the implant, and the prosthesis was cemented on top. And that caused problems. We now know that screw retained prostheses are much better. And we're also in the era where most at a higher percentage of your prosthesis should or can be screw retained because of the angle screw channel, which is on the right here. It gives you some leeway, 25%. So even if you back in the day when you were limited and you had to do cement retain, now you can do angle screw channel, for example. And on the lower left, you have multi-unit abutments. And these are on bone level implants. If you want your prosthesis to be at least tissue level, you can put multi-unit abutments that degrees on them, 30 to 17. These are mainly for full arch prosthesis. Where you want, the advantage is when you're providing the prosthesis for the patient, you want it to be comfortable for the patient. When it's implant level, which is fine and it's possible, it might be a bit painful for the patient. It's harder to see whether you are directly sitting on the implants well, because you have to always take radiograph. Whereas if you have multi-unit abutments which are tissue level, once you place it in, you can visualize that everything is sitting well. It gives you leeway in terms of if you want to avoid the sinus, for example, and things like that. And then on the lower right, you can see locators that help with attaching dentures for patients. And different abutments have materials such as gold, titanium, and zirconia. Now, let's now go towards once you've placed the implant in, or once you're planning actually to place an implant, the first thing that you do is you have to do some treatment planning. Now, a patient will come into you, like on the diagram on the left there. She is missing some teeth, some premolars, the canine is fractured, and she says that she doesn't want a denture. She doesn't want anything that's going to affect the neighboring teeth. She wants implant. The first thing that we have to do is to treatment plan. And we are also at the time where implants, when you're planning implant, it has to be prosthetically driven. Dr. Umar, as a prosthodontist, will be very happy to hear that, especially I'm sure, because and it's not always been the case. I myself I'm not perfect, and back in the day I can honestly say that I was not following this principle. And where I saw the bone is where the implant was going. And if it's going, and you worry about the prosthesis later. This is different now. You have to plan from you have to plan from the end. You should know where your end is, and then you start your planning, and you continue your treatment. So you have to start off with the wax pattern. Know where the teeth are going to be, how many teeth. For example, here you can see that with the space that the patient had, you could only put one premolar. a large molar there, one canine. There's already a canine a root fragment there. What are you going to do? Are you going to extract? Are you going to extract and preserve? Are you going to do immediate implant placement and provisionalization, for example, things like that. You start planning with your diagnostic wax up. And that's what I'm going to just briefly go through right now. So in this case, we did a wax pattern for the area. You can see that the patient previously had fixed dental prosthesis in the area. It fractured. You can see a radiolucency there. That's something that you're going to be mindful of as you're doing your plan as well. So initially you do a panel, you have your wax pattern, but the gold standard is, of course, a CBCT. Now, back in the day, of course, CBCTs are not new. They've been around for some time, but they're gold standard right now if you're planning on putting implants. Because the CBCT is the only way you're going to visualize the bone that you have, the volume of bone. It can give you a rough idea of the type of bone that you have. It will definitely help you with viewing landmarks that you want to stay away from. In the maxilla, you're worried about the maxilla, the sinus. You are the width of bone, for example. You're worried about in the mandible. You are thinking about the nerve and things like that. So you have to do a CBCT. And in this case, we did a CBCT. And this is just a short video showing what we did. You can see that we did a scan STL of the patient's current state. That's on the left there. You now also scan the wax up that you've created. Now, when you have the STL of the wax up, you have the STL of the current state, you have your CBCT. You incorporate everything. You put everything into the software, whichever software you're using. There's Blue Sky. There's so many different softwares. And you now place your virtual implants. And once you have your virtual implants in, you start playing around. You see, okay, if I place my implant here with where I want my tooth to be, do I have space? Am I far away from the sinus? Am I far away from pathology? Do I need to consider grafting, for example? Should I consider a different treatment altogether? Because sometimes you cannot place implants, and you have to tell the patient, unfortunately, we can't place implants in you. We have to go back to a regular bridge, for example, or removable prosthesis. In this case, you saw that we're planning to put 3 teeth for the patient from the diagnostic wax up that we have created, and now you want to know: am I going to put 3 implants? Does the patient have money for 3 implants? 3 implants, so it's a good option. But if you remember nicely, if you step back, remember there was that pathology. We sent the CBCT for interpretation, and they mentioned that it could be amalgam. It's nothing to worry about. It's not really a pathology. It's just a sighting. So we went ahead and just said this patient can benefit from just 2 implants, one in the canine region, one in the molar region. Now you step back and say, now there's already an existing root tip. Should I extract that, put implant right away and do the other implant and then wait for the patient to heal? We decided not to. In this case, we did it differently. We decided to wait, which is a bit more predictable. And sometimes your patient won't really agree with you where you want to be conservative. But we had a good patient who understood and wanted the best outcome. So we extracted the canine, as you saw in the CBCT. We did ridge preservation, and then we did another CBCT. After we did the CBCT after the extraction and ridge preservation, and that's how we went ahead and placed the implant. Now, this is another case. Patient comes in and they want to place the lower right. This is you do diagnostic wax up, which is what you can see there in green as the STL, and now with that the same thing. You superimpose everything in place. You have the CBCT, the diagnostic wax up. You place your virtual implants, and then you see if I place my implant in this position, and with where my tooth is. How does it look in the bone? Is it outside of the bony housing, for example? What size implant can I put? In this area, you can definitely see that if I place implants in that position right there, you can see that it is completely exposed on the buccal, like completely exposed in the buccal, and we don't want that. The patient's bone was more of knife edge towards the crest. So we in this case we say that it's perfect, it's ideal. Someone can say that, as in, let me also step back and say that this what I'm talking about is, of course, opinion for my training, and people have different ways of attacking different situations, and I understand that. What I'll be talking about is my thinking process when I see certain cases. So in this case, I say that I was thinking that there's no way that we can plan to place implants here. We definitely have to do bone graft first, a GBR, and then later on, once we have created bone, then we can proceed and place implants and proceed. And that's what we went ahead and did. So this is the beauty of of prosthetically driven implant placement. Once you know where your crown needs to be, you now know where you want your implant to be, what size of implant you want to be there, what away from what landmarks, for example. So in this case, we went ahead and of course flapped the area membrane. We did decortication. In fact, decortication right nowadays is controversial, if I may say that. If you watch the surgeons nowadays, the well-known surgeons out there that do GPRs and things like that, most people are saying that decortication doesn't really benefit you that much. It might be controversial. I don't know what you guys think, and we can always discuss that later. It might be doing more harm than good. Now, this patient, she was a current smoker, which is not great. She was on her way of stopping, but she was a current smoker, and she was on SSRIs, depressants, which we all know affect implants themselves and also graft. It might not be the best outcome, but we went ahead. She understood the risks, and we went ahead. Now we grafted the area, we closed up everything, and we waited more than 6 months, actually. We had a mixture of autogenous bone, about 20%, and then a mixture of allograft and xenograft. So the 20, 40, 40. We got some autogenous just from the posterior region here, and then mixed everything in. So that's the donor side. You can see that it was flattened out. We went and did the GBR. So before the GBR, you can see not knife edge, but it was quite thin. After the GBR, we got some bone, but not as it, to be honest, I was not very happy. I got some bone. I was not very happy, but there was something that you could work with. Now your treatment can change. You can say, you know what, I got something, but maybe what implant placement, we can do another augmentation and then have more bone and we can proceed. That's the other side. You see this side also was quite thin on the left, but then there was bone gain after some time. And you can actually see the tack that was holding the membrane in place. And that's how you go about your planning in implant placement and surgery. Now, let's look at another case. This is a case on the anterior region now. When you see this in the CBCT, it's before even doing any wax up and anything like that. Not saying that we didn't do it for this patient, we did, but you already know that there's not enough bone here for us to place an implant. Or even if there is, it will be a thin implant and you run the risk of either perforating the apical bone there, or you're not too worried about the insides of nerve, but you don't want any granulation tissue around or soft tissue around that implant. So we went ahead and just decided, you know what, let's do a GPR. And we did a GPR. This case came out looking much better. You can see the width that we got. And we proceeded on to place an implant. You know, when you open up and you see a ridge like this, you're very happy. And the reason why especially in the anterior region, because when you want width, you have, because like we said, you want to have a screw retained prosthesis. If you want to have a screw retained prosthesis in the anterior region, if you're not using ASC, you want everything, your accessor to be coming out in the singular. And that means you're tilting your implant at the apex. If you want enough bone at the apex there so that it doesn't come out to the fascia of the bone. And when you see this bone here, we're very happy. We did the surgery. We did the implant placement. When you see this also in the radiograph, you're very excited. You're very happy. You see the tags there. Everything is integrated. The patient is happy. And this is, and then you do a CBCT after, just to confirm. We don't always do a CBCT after implant placement to see how everything is. It will be very good to do that all the time. But to be honest, we don't do it all the time. Sometimes we get the chance to do it just to know how everything went. And in this case, we did it. You can see the implant is in the bony housing. We grafted the incisive canal. There's no soft tissue around it. We didn't perforate the plate. It looks good. And we had access hole through the cingulum. We didn't have to use an angled screw channel. Now, is this another case? Now, you look at this case, you think, oh, this is the same thing. Implant was placed, looking good. Radiograph seems like everything's fine. This is a good day. Like going back to the title of what we're talking about today, the good, the bad, and the ugly. You'll be excited when you see this. You say, this is quite good. But then when you take a CBCT and you see this on the lower left, that's not a good day. This is quite bad. You're not happy, as in, and this was an incidental finding. I could have I could have just shown or seen the radiograph before the X-ray and noticed that dislingually I'm within bone. I'm happy. There is no obvious bone loss, and I would have been good. Now, this patient came back and they wanted to do an implant at another site. And when we did the CBCT, of course, we had already placed this implant. We said, let's go see and see how our placement was in the anterior region there. And when you see this here, as in, it's truly humbling. As a dentist, most of us are perfectionists, and most of us want the best, want to do the best. This is almost like a sleepless night for you. You're wondering what happened. Was it what was I trying to do? Why did I do this? And there's one of my professors always says that if you do not have any failures, if you don't have any dental failures, whether the prosthesis or implant itself, you will most probably not done enough implants. Um, I have my fair share of failures, as most of you might have if you've placed a couple of implants. So in this case, we saw this one, we're not very happy. Now we went forward and now this is the realization that you have to that I had now. Why I was thinking back, why would I have that loss of bone or the perforation or of the buccal plate in the apex of this in this case? And it was quite obvious what I was trying to achieve here. I was trying to achieve is to provide a screw retained prosthesis for the crown. It wasn't restored by me. It was restored by the student. But I was trying to provide a screw retained prosthesis for my patient, meaning that you wanted the access to be to the cingulum. And then when you want it to the cingulum, you're not in as much as you want everything to be prosthetically driven, you should also be mindful of where your bone is, where your bone could be. And one thing, another one of my faculty also says they don't like flapless surgeries. He wants to see everything, and when he does his surgery, he's seeing everything. In the anterior region here, maybe you might argue and say, you know what, why don't we do flapless? You want to preserve the papilla, you want to do all those things. He says there are other things that you can do to get your papilla back. You can do papillary sparing. He just wants to see his bone. So when he opens up everything, he wants to see where my implant is going to be. He's using his probe. He's really planning to make sure that everything is within the bone that he has. And to be honest, I didn't do that in this case. I had flapped, yes, but just at the top. I was not mindful of what is happening at the apex. And that's what we did, and that's why we had that buccal plate perforation. Now we went ahead and monitored this patient. This picture is over a year after placement of the implant, and after the patient has had that crown in place for over a year. we are now looking out for the gray shadow of the implant. When you see that kind of bone loss, your gray shadow, soft tissue loss, and things like that. But in this case, there was nothing. We did bone sounding. We probed around the area, and what we are thinking is the case here. There is bone at the coronal part of the implant, and then the fenestration, the dehiscence is more apical. So because you have the bone at the top here, most probably that's why my soft tissue is still in place. You can't see any gray, but you never know. You don't know how long this is going to last. We have to continue monitoring this patient, because as soon as you start seeing any problems, bone loss, gray, then the patient is aware. We of course told the patient that this is the case. It's not a concern as of now, but let's be mindful of it. Now, it's also known that most of dental implant failures come about after 5 years. And so if you've been placing implants for a while, after 5 years, that's when you start noticing people coming back, oh, doc, this is happening, I'm getting this, what do we do? So this patient is going to be monitored and see how everything goes about. And then something also interesting that some of my faculty say, or a mentor of mine would always say, because we know that after 5 years, that's when you're going to be getting failures. That's when you should plan to keep moving around. If your practice is in, I don't know, Bukolobi for a while, move to, I don't know, Kasangati for after 5 years, so that you get a whole new pool of patients, and those ones that you messed up, not really messed up, but had an issue with, are seen by someone else. That's just a joke. I'm not saying that we should do that, but he says you move around and you can proudly say, then you can proudly say that I don't have any failures, because I mean, you never see your patients after 5 years. Now, this is another case here. When you see this, what goes to your mind? If only this was interactive, it would be very interesting to hear what your thoughts would be. But if when I got this case, there's several
we
things.
can pick people's minds if you want us
No,
to.
yeah,
I mean, that
no,
looks
if
interesting.
yeah, as in if people want to chime in, as in I don't want to be talking the whole time. If someone has and also Doc, if you see anyone asking any questions, that you please interrupt me, and we can
Yeah,
always discuss.
I will. You can
Yeah,
go on, but just letting people know that if there's someone who wants to ask a question, please raise your hand, and then we can just pause and see what we have to discuss. For now, you
exactly.
can continue, but if there's anything in the chat or even just unmuting yourself or something with a hand up, you should be able to see
Yeah.
that. Yeah.
Yes,
Okay,
please.
Doc. Mm.
Yeah. So when you get a case like this, several things are going through your mind. I'm not going to mention what the patient came in complaining about, but when you look at it, you start seeing that in the maxilla here, you see the implant here. You might say that the implant to crown ratio is a bit suspect, but we know that short implants work. Bicon implants, which are tiny, they work. So we're not so worried about the implant to crown ratio here. But then you see the size, maybe the platform, the diameter of the implant might be of question, for example. It's a rather small, short implant, not short, but smaller diameter implant. But in a bounded site where you have teeth on either side, you can say, I'm not too worried about that. I don't think I'll be worried about any complication. Yes.
No, go ahead.
Oh,
There's some interruption. Yeah.
okay. You say in a bounded site, you might not be too worried about any possible complication there. You say, okay, fine. Now, you go to the mandible there, you also see a rather a thin or smaller in diameter implant there. And this one is not at a bounded site, it is a terminal tooth. There you'll be a bit more worried, because now any axial forces, eccentric forces are going to act more so on that implant and might cause problems. And that is exactly why the patient came in. He was complaining of constant screw loosening. He had gone back, these implants were done so the patient came to us in the school, but they were done in a different country. And he came back, he says, I went back to the dentist, he fixed something, he checked occlusion, he fixed occlusion. In fact, when she came in, there was no contact. There was, as in the shim stock and occlusion articulating paper was going through, there was no real occlusion in that area here. So you can tell that they were trying to fix something. But he kept on having screw loosening. So what could be the issue here? Now, when you go through, you look at the CBCT, you can notice that, fine, the implant in bone, but it is a small diameter implant. You can see it is quite lingual. Now, if you like step back to what we just talked about, where you're going to do everything prosthetically driven, if the crown was in a place where it needed to be, you can imagine where the implant itself was. It is more lingual. That means you have a buckle cantilever of the crown. And I don't know if you can see that there. So we did a slice, we checked everything, and you can see on the lower there, that red is a buckle like cantilever of that prosthesis there. So in as much as there's no occlusion on this tooth, the patient was, this, of course, as he's eating certain types of food, there is going to be some type of load or force on that tooth that can continue causing that screw loosening. And that's what we were suspecting. So he was complaining of screw loosening and a foot trap. So you might say, you know what, I do this all the time. It's not a problem. And it might not be a problem. For example, like I said, if it's in a bounded site, like in the maxilla here, you could be quite safe. But now you run the risk of foot trap, for example. Some patients are complaining of foot trap. Now, if there's foot trap, it might not be an aesthetic problem. But foot trap can also be, in as much as it's not a prosthetic problem, it can be a biological problem. Because if there's foot trap, that means the patient is not able to clean nicely. You are running the risk of causing peri-implantitis in that area, on that implant, and later on losing it. Now, what do you do here? We told the patient that these are several problems. In fact, I should also step back and say, in as much as the patient is also having screw loosening, you might also not, in as much as this is a prosthetic problem, it could also just be the type of screw that the patient had. Maybe if you're using third-party screws, that can be a problem. So we told the patient that the implant position is not ideal. There's nothing much we can do right now. It's not a bounded prosthesis. I'm going to talk about things that you can do to mitigate such problems. But we told him that either we change the size of the crown itself, or remove the implant, step back, and maybe do GBR. But he's an elderly patient. He's saying it's screw loosening, this foot up, but I think I can push on for a little bit. And we didn't actually do much. We just tightened it, changed the screws, tightened it, and told him that whenever it happens, just please come back. I'm going to talk about that topic again in a few slides. Now, when we talk about the screw loosening and all that, now we have to talk about the complications. And the most common complication for single implants and crowns, and this is from a paper from Dr. Kibuuka that was compiled, it is abutment screw loosening, which is the highest percentage. The next one is abutment screw fracture, and then implant fracture. Now, if you go back to that case, you definitely have to tell the patient, yes, now it's this screw loosening. You run the risk that later on, if nothing is done, you might get screw fracture. And if that doesn't happen, sometimes because it's a terminal molar, though you've adjusted the occlusion, but you never know what if you eat something hard at some point, that implant might actually even fracture. Now, we've seen implant fractures. They're not common. As you can see here, they are 1% to 3%. They're not very common because titanium is a very strong metal alloy that implants are made from. So it doesn't really happen as often, but it could happen. Now, if that was a zirconia implant, that's a different story altogether. When you're placing zirconia implants, you have to be even more mindful. Because zirconia implants, just as we know from zirconia, it can easily fracture. It doesn't give you that this goes back to dental materials, the flexibility, the tensile strength, and things like that you get from a metal alloy like titanium. Doesn't give you that flexion. Zirconia, if there's any flexion, for example, if that was a zirconia implant, most probably it would have fractured, and that's a huge complication. So if you're placing zirconia implants, most of them are for the anterior region. If you're going to do the posterior, make sure that it is a bounded site, enough bone, there are no excursive movements, there's nothing that will cause unwanted forces on that prosthesis, lead to fracture. So those are the most common complications that we have there. Now, and the causes of those the screw loosenings, there could be mechanical overload, which was the case in the one that we had over there, component fit and binding. Now, component fit is like, for example, the abutment itself fitting into, if you step back, we talked about the internal hex and the external hex. Nowadays, we have the internal hex. The abutment sits in the implant, and each component, like Straumann, Nobel, whichever component, Dr. Umar knows, Braident, for example, they manufacture their abutments, their connection and implants, so that there is an intimate connection between the two to form that soldering, the caudal lock mechanism that keeps the abutment in place, and then you still screw it in. So if you've ever removed a internal connection abutment, in fact, Dr. Umar, Dr. Umar,
Sorry. Yes. Yes.
um, can you just take a short, maybe 3-minute break? I just move quickly to another room, then I proceed. If there are any
Sure.
questions, you can,
That's okay.
yeah,
Okay. I think we could pick it up from there in a few.
yeah,
All right.
just yeah,
I It's okay. I can take over for a few minutes as you do
yeah,
that.
just move quickly.
Okay. So I don't know if there is any questions so far as Dr. Han. So it's very early in the morning for him. So we might hijacked his morning. Yeah. So I don't know. I think where Dr. Ham had stopped was talking about the especially the complications. And I hope we can be able to get Dr. Gudeka sometime. These are gurus in prosthodontics. But of course, these are people who talk to millions of people and who are respected in the craft and also in implantology. But
Yeah,
these are key papers that we look at when we look at failures of implants. And
yeah,
prosthodontics or prosthetic part is actually one of the biggest failures. So the prosthetic failure of implants, because so many
yeah,
of us just I'm going to place an implant, I have a bone, and that's where I'm going to go.
yeah.
But later, five
True.
years down the road is where everything comes back to bite. Yeah.
Exactly.
So
I'm
I don't know
good.
if
I'm
we
now
have any
situated.
questions so
Yeah, I don't know
far
if you have
before
any
Dr.
questions. Yeah.
Ham continues. Anyone with any questions? Okay, I think we're good to go. So floor is yours
Okay.
again.
So let me continue. So we're talking about the component fit and binding. Like I said, each company has it's specific. You want to use the abutment for the right abutment for the type of implant that you're placing. Now, if there are third party abutments and screws out there, and it's possible there's a reason why those companies are in place and are thriving right now, because there is a place for them, but that can also cause possible problems. These are conversations that you should have with your lab. Now, you talk to your lab and say the components, the abutments that you're manufacturing your crowns on, your prosthesis, your FPDs and everything that you're giving me, are you using because when you do your lab form, you say I've placed a Straumann, a Nobel, a Braident implant, such and such type of implant platform and everything, please give me a crown. They should order Braident components for your prosthesis. Because if they don't use the same type of same company, you run the risk of not having that intimate connection. And when you don't have that intimate connection, that's when you get such problems that abutment screw loosening, the fractures and things like that. Now, it is one thing that when I started my implant journey, if I can call it a journey, or when I started placing implants back in the day, some of these concepts I was not aware of them. I was not aware that there's a prosthetic screw, there's a lab screw, for example. When the lab is manufacturing your prosthesis, they're using a screw in the lab. You can imagine what kind of dust is on that screw, what kind of metal is already on that screw. Now, when you use that same screw in the final procedure, place it in the patient's mouth, that screw has been tightened several times. It is already at the end of its limit. Now, when the patient comes back after using that screw, patient comes back and is complaining of screw loosening. You're wondering what's going on. I've done everything I could have done. There's bond, it's a bounded site. The contacts were perfect. What have I done wrong? Those are things that you have to think about. You have to plan, know that for us here, I don't know if it's the same there. When we get the prosthesis back, if you get a single crown back, the lab will give you, of course, sometimes it's mounted on the cast itself. That will be the lab screw. You take it out. They always give us the box, the unopened box of the prosthetic screw that you're now supposed to place into the prosthesis and then deliver to your patient. There you know that I've done the best I could do. So sometimes you want to do the best you can so that in case anything happens, you are covered. You're covered. So these are things that
To
you have to
answer
check.
that,
Yeah.
I think
Yeah.
labs here actually don't.
Mm.
Of course, when you do implantology, that's when you find out that most companies have now color coded it to be a blue. So if you do not get a blue, I think even Stroman does the same. Stroman,
Yeah. Yeah.
Skybrident, Dentsply, implants, all the other lines currently, when you don't get a blue screw and you get a silver screw
Yeah.
or some red, I mean gold. I think
Exactly.
Megagen had gold at some point. If you don't
Mm-hmm.
get those colored implant screws, then know that you have a lab screw, and those are going to
Uh-huh.
cause you issues. But I know here the labs
Exactly.
don't provide that. Yeah.
Yeah. So and back to what you just said, Dr. Kizito, even if they don't provide, as in, even if they're giving you back the prosthesis with the final screw in, I hope they should at least say, you know what, in the lab we didn't use it, and we have already just placed it in for you. It's new, nothing. You should have that talk with your lab so that you know that what you're putting into the patient is something that is solid. Now, back to mechanical overhead component, so you check the proximal contacts, make sure that the floss is going through. There's just the right amount of pullback. Heavy occlusion, you don't want heavy occlusion, eccentric occlusal contacts. Now you want everything to be sitting nicely into the implant. This is where the beauty of the platform switching comes in. If the platform is 4 and you're getting a 3.6, you're almost pretty sure if your abutment is tall enough, you're not going to be causing any pressure on the neighboring bone, for example. Back in the day, it was more of a concern because if you're doing platform matching and you're placing the abutment in, there was a chance if you had that slight ingrowth of bone, for example, anything, the abutment will not sit. So you're forcing it in. That means you're forcing the screw, you're tightening the screw. You have not done your radiograph to see if everything's sitting well. Of course, you're going to get loosening. Then tissue of bone, preventing complete sitting, and then not using the type. Another important one is not using the type, the correct torque value. We And as a thought this back in the day, I never used to. Nowadays the standard of care, like you said, the same way you do a CPCT when you're placing implant, when you're delivering, when you're doing the uncovering. If you're not doing if you're not placing healing abutment at the same time, take a radiograph, see how the healing abutment is sitting in the implant. Taking those radiographs. When you make your impression, whether it's using a scan body, whether you're doing open tray, closed tray, whatever it is, once it's in, take a radiograph to see that it's sitting well. Then when you get your crown back, sit the crown in, take a radiograph so that you are monitoring, you're seeing the whole step, because this is bone level, you're not seeing anything. You might put it in, you might feel tight, you say, oh, this is good. You connect. Sometimes you put it in, it seems high, you adjust the occlusion, but yet the occlusion is high, you're complaining and saying my lab is giving me bad prosthesis. But the fact is the thing itself is actually not sitting well in the implant. Take a radiograph, see how it's sitting, then start the occlusion, adjusting and doing all those things. Now, talk value. Back to talk value. Each company will give you what their requirements are. The standard talk value is about 35 Newton centimeters, but that also depends on the type of implant and the size of implant that you're placing. Most narrow, like RC regular platform, like of course each company has different names. 35 should be the standard. But now we have the smaller diameter implants, maybe the 3.0, 2 point something. Those ones are usually not talked to 35. You have to, I think it's maybe 15 or 20. It depends on the manufacturer. Please read the instructions so you know that this implant, the size of implant that was placed is this. This is how much I need to torque. Because if you torque too much, an implant that is not meant to be torqued to a certain value, then of course you're going to cause problems. Not only abutment screw loosening, but you're also going to cause the implant itself, implant failure, which we don't want. In the US here, it is there's a lot of referral. Like for example, we work in our department is a specialty program, so we get referrals from the main clinic. We have our own patients, but we also get referrals from the main clinic. Now, when I place an implant, if I'm going to place a smaller implant that does not need to be torqued to 35 Newton centimeters, for example, all those I write everything inside my notes, and the person who's going to restore that implant should read those notes. Should not assume that, oh, this is an implant 35, let's go. You should read the implants. So this is the notes. This is the type of implant that was placed. This is the amount of torque I need to apply to this implant. And it's not only single implants. We talked about multi-unit abutments, for example. When you're doing a full arch, if the multi-unit abutment itself is torqued to 35, if that is what the company wants you to, is torqued to 35, but the tiny screws, the tiny prosthetic screws, the one that fit the prosthesis on the multi-unit, those are not torqued to 35. When I have one of my residents here who at the beginning, when he was told try in a prosthesis, in your head you say, oh, 35, you've memorized everything. The guy went in and he was talking everything, he kept on breaking. I was wondering what's going on. Those are not meant to be torqued to 35. Those are usually just hand tightened as much, or if anything, 15 Newton centimeters. So be mindful of the torque value that you're supposed to be providing. Now, this is a case here where the student was supposed to go ahead and give a prosthesis to the patient. Now, you can definitely see the student did the right thing. They took radiographs at every step, but they were not aware of what she didn't know what she was supposed to look out for. So, of course, this is, like I said, in the US, because of the referral and everything. When I've placed the implant, of course, I know how I'm going to proceed to restore it. But if you're working in a situation where, like, for example, you've sent a patient to Dr. Kizito, and he's placed the implant and he's sending the patient back to you for the crown itself or whatever. You have read his notes. You should now know how you can proceed with restoring this thing. Here, the patient, the student didn't place the scan body well, and you can clearly see it in the radiograph. Now, when the crown comes back, it is almost identical to how the scan body was. The crown was not sitting, and they were wondering what's going on. How come the crown is not sitting? We can clearly see that it's not sitting, it's not engaging. But that you step back and say, but the scan body itself was not sitting. That could cause problems. Now, when the scan body is sitting well, then the crown should sit well. Just minor adjustments. Now, this case that we was mentioned that was not done correctly, they ended up now doing everything correctly. They did analog impressions, and then the patient finally got the crown in, and it was sitting well. Now, things that could cause implant problems or failures or prosthesis failures could be, like we mentioned, um, not considering the size of implant and the prosthesis that you're going to give you. There is a paper. There's a paper that was written back in the day, 1989, actually, by Ranget, and he was talking about posterior guideline, or based on Ranget, on the overload potential, and which is greater in molars, but essentially put a larger diameter implant in the molar region, and so that you can have the appropriate size molar for that side. So he was saying that if it's a 4 millimeter diameter implant, the cantilever, left, right, buccal lingual, should not be more than the diameter of that implant. So if it's 4, you just spread 4. If it's 5, you just spread 5. You go 5. If it's less, perfect, you're good. Now in the molar region, you don't want to put a 3.5 implant there. You can, if you say, you know what, I just want to place a 3.5 implant, then put two of them, and then you mitigate this complication here. You stay away from this complication. But if you're going to put a 5 or a 3.5, for example, in the case I was showing you before, where they put a smaller diameter implant, but there was a larger cantilever towards the buccal, that's not acceptable because of the forces that can be exerted on that prosthesis that can lead to the screw fracture, screw loosening that the patient was having. And this now goes, it's a circle. It goes back to how we plan our implants. If it's prosthetically driven, you know the size you want, you know what diameter of implant I'm supposed to put in to match the size that I want, and then you won't have such problems. So that, like I said, it goes back to what we had here. Those principles are not being followed. And like I said, if you do place a smaller diameter implant in that area, then it cannot be that wide. Then you tell the patient that unfortunately we have to reduce. So like I was saying earlier, you can tell the patient, you know what, because the screw loosening, we can change your screw. We can make sure we have the right type of screw. We can change the prosthesis itself. We're going to change the crown and make it a smaller diameter crown, so that if it's the 3.5, the cantilever on any side, measured distally, buccolingually, is going to be 3.5. If a patient, as in the patient might not be happy, but if it's already done and they're not willing to go through GBR, the new implant later, say if you will work with the case, with the situation that we have right now, then we're going to change everything, make it a smaller diameter, change the table, the occlusal table of that prosthesis, so that you get away from possible complications. Yes. So now, so when you have that cantilever here, if you can see that prosthesis on the far right, so the potential for mechanical overload is increased when the implant is not centered beneath the occlusal surface of the crown. And this is from the article that Dr. Godeka wrote much earlier on. So we try and make sure that the implant is positioned as central as possible. Sometimes it's not possible, but there are ways. Like I said, in a bounded site, you might be able to get away with it. But if it's possible, please center it. Now, when it's not possible like that, where you have such a cantilever to one side, in as much it can be a prosthetic problem, like we mentioned, but it can also be a biological problem. There's a paper that was published in 2017 by Katafuchi. It was his master's thesis, actually. They went and they did radiographs and followed up cases that had failures and peri-implantitis and things like that. And what they noticed was when the emergence angle, so from the implant itself to the prosthesis, if the angle was more than 30%, 30 degrees, sorry, more than 30 degrees, there was a higher chance of peri-implantitis. So, so
it's not only a prosthetic problem. You might not just get screw loosening. Maybe the screw and everything will not affect you, but you might run the risk of getting biological problems. And that is also not a very good thing. Those are bad of the implants. It can be very ugly. So remember that. Remember, if you want it less than 30%, that means you have a wide enough platform implant, and the prosthesis is the right size. Now, there are 4 factors that can affect implant loading. And so these are things that you can do. I already mentioned the horizontal implant offset. In that case that we had, this one here, that's one thing that you can fix. Just fix the horizontal implant offset, so that the load on the implant is not so much. This cuspal inclination, these are things that you can talk to your lab and tell them, make my cusps not so inclined, as indifferent, whatever. You wanted a flat occlusion, for example, so that there's in movements, certain movements, they're not, you don't have those axial forces on the prosthesis. Implant inclination. So for example, if you have your arch like this, you don't want an implant that is placed like that. Because if the load is directly onto the implant, you can imagine what kind of force is going onto the implant there. So you want your implant as parallel as possible. And then apical implant offset. That's up and down. This is Weinberg. This is 1995. Short implants work, so you're not too worried about that. But you try and match the implant crown ratio if possible. Now, so the methods for resisting adverse leverage. So like I already mentioned, if you have to put small implants, then make it 2 implants to support 1 molar. That's possible. Use wide diameter implants. You always want that. And this is also, for example, Dr. Kudeka, when he is placing, is one of our mentors, if he's placing several implants in the posterior, he always splints. He never does single. And there's certain advantages that you have to that. When it's splinted, so first of all, when it's splinted, it is much easier to restore, because you're not, if someone has restored, if one of you has placed in different implants on a patient, maybe 3 that are individual, you can imagine the amount of check that when you're adjusting the proximal contact on this one, you adjust the other one, you torque it in, you take it out. There's so much that goes on when you have a non-splinted prosthesis. Whereas if you have a splinted prosthesis, it's one. The patient can definitely clean there. You can show them the things like superfloss, interproximal brushes. Cleaning is not a problem. So it's easier to restore, and it also helps with the leverage and resist the forces on a single implant, for example. So if you splint them, you are at an advantage. So connect them with splint and then decrease the facial lingual dimensions. Now, when you splint them, this is also something that is debatable, but we would like to do 1 engaging, 1 non-engaging. And engaging is when the abutment is sitting in the implant flush. While non-engaging is when it's not it's sitting. It's more like not external hex, but it's more like external hex. It's sitting on top, so it's not really engaging the walls of the implant. So 1 engaging, 1 non-engaging, everything should be good. All right. Now this is another case here we had. Now the patient comes in. He has failing 1-1-2-1. Now like I said, you go through the whole process of diagnostic wax up. You superimpose everything in, and you plan your case. So you can see here the STL is the blue the outline you want. In this case, you wanted to do immediate. It's an anterior aesthetic case. The patient was high on aesthetics. He says, if possible, please give me something. Now, these are the cases where your A game has to come out, because aesthetics is what really builds you. So in this case, we went ahead and did the wax up. And from the wax up, you already see that the axis for this, the axis is going to be very, it's going to be incisal. And if it's incisal, it's not bad. In this case, we also did socket shield, but if it's incisal, there are several ways you can go about it, and I mentioned them before. You should not be worried that I should aim to always have my access hole singular, because you run into the risk that the problem that I had, where your implant and the apex will they will have a fenestration. In this case, we did the angled screw channel, and we were able to provide the patient with a temporary prosthesis on the day using an angled screw channel. So we given the patient something screw retained, so nothing cement retained. We're giving the patient something that is immediate and is aesthetic, and the patient was extremely happy. In fact, there's a short video here. It just goes through, and of course it was fused, because you want it fused so that in case it is any actual forces, they're well distributed. In case, and that's how. So this case is not been finished yet, but if you do proper planning, everything should work out well. You should have a good day. Now, this is another case. Now, when you get such a case, I'm like I said, I wish this was more interactive, but now you imagine what is happening. The patient comes in, she has a denture. I'm going to show you the denture, but you can clearly see that. Well, I can see 2 implants in. They don't look like they have healing abutments of school or what's it called? They don't have the covers. And she's asking for you to do something. Now with the denture in, can you see where that where that implant is coming out, where the axis of that implant is? It is coming out extremely facial, extremely facial. If this was my case, of course, it would be a bad day, and I would not want to say this is my case. And luckily, it's not my case. But the patient comes to us and was asking us for a solution. And one thing I've also learned is you don't know what happened with the previous dentist, what was going through their mind as they were planning this case. Of course, never bash them. It's never right. I'm sure if you see someone will see your work somewhere else and might also question it, but just you have your own opinion. So like I said, no cover screws and these implants here. This one is coming out facial. It's very thin. What is going on? You look at the radiographs here. Can you see how close those implants are? We know that we want our implants to be at least 3 millimeters apart from each other. This is so that the prosthesis has a good profile. That's one. There's always bone remodeling. If you go back to osseointegration, there's always bone remodeling after placement of implants. Now, if they're too close, at this 2 millimeters, you have bone remodeling up to 1 millimeter. Now, if they're next to each other, there's bone remodeling. Is there going to be any bone in between there? Most times not. And if there's no bone there, that's a good case where you get peri-implantitis. Now, in this case here, you see that the implants are very close. That's not good. This one was facial. I don't know what is going on. These are the ones here, even closer than the other side, and they actually even placed the implants in. This patient came to me so she came earlier this year, and these implants were placed sometime last year. So these have not been in place for a very long time, but you can already see the bone loss that has already taken place. And when you look at these radiographs, you start going into the mind of the person who was placing these implants. I am pretty sure that they were worried about getting into the sinus here. They're saying, you know what, I want to place 2 implants here. The patient needs 2 implants. That's in their thinking. But if I place an implant more posterior, I'm going to get in the sinus. I'm afraid of that. I don't want to do that. They didn't want to refer. They said, no, let's just go ahead and squeeze 2 implants inside there. Problems. And you can definitely see, because they don't want to get in the sinus, they made them so not subcrystal, supracrystal, which is not good. The one in the front, the canine one, I really don't know what the thinking was there. But the one also in the other side that were actually loaded, it's the same thing. They were so close to the patient, I'm sure they were saying, you know what, I don't want to get into the sinus. How should I stay away from the sinus? This is now a case where you have to refer. If you're afraid of doing something, if you're not capable, send the patient. You can always send the patient to oral surgeon. Send them someone who's capable, someone that you've seen do some work. If they can do a sinus augmentation for you here, you wait, let it heal for 6 months, then you come back and place implants, and it will be a good thing. But now, if you want to do everything all at once, that's the problem. And if you also look nicely, you can actually see that it's actually not even sitting well on that abutment there. That was this is now more. This is closer to the ugly of implants. Not good at all. So in this case, we had to tell the patient that, you know what, unfortunately, there's nothing much we can do. You can't restore these implants. The best way is to actually remove everything and start afresh. Remove everything and start afresh. And now when the patient hears that, of course they ask, so what happened? Did the other doctor mess me up? What happened? You say, you know what? I was not in my what I usually say is, I was not in the room when this was happening. I don't know their thinking process. What I can say is, if you had come to me then, and what I'm seeing now, as in I have a totally different way I could have approached this. So I'm just going to give you what I think I can do now, and then it's up to you now to do what you want with this information. But it's a actually litigation case. We had to write up a report of of our findings and what we think needs to be done, and the patient went back to claim some money, and I think that doctor might be in some hot soup. But this all goes back to not proper planning and, of course, trying to do more than you should. Now, this is another case. Now, this case is actually mine. I've been talking, as in, it's like I said, you can never. It's always good to be honest, and I'm going to be very frank with you. This is actually my case, and this is one of the cases that didn't turn out good. It was not a good case. This patient comes in, and there's several things that led to it, and I'll mention everything. If you can see, the bone is they need an implant in this area here. The bone vertically is not enough. I was thinking that instead of doing a lateral sinus augmentation in this case, why don't we just do a vertical, a bump, versa? Let's just do a vertical sinus augmentation and place an implant there. Yeah, I'll say a bit more later. Now, went ahead, you just a versa drill, you did the whole protocol, followed the protocol, placed and then placed the implant in. Now, for honesty's sake, what happened was we had a perforation. On drilling, we noticed a perforation because with Versa, as you're using, I don't know if any of you are familiar with the Versa drills, but you use them in reverse. They are for osteocondensation. So luckily there's not a lot of bleeding, so you can actually see what is happening. It's more white because it packs that bone into the area. So when we looked through the mirror, we could see that, oh wow, there's a perforation there. But I thought, you know what, it looked like a small perforation. I said, you know what, let's just go ahead and place implant. And we did. Now a patient comes back after some time, they write you to call you. Of course, okay, let me step back. When you have a perforation, when something happens, always notify your patient. And we did. We told the patient, you know what, there was a perforation. We put some collagen membrane in there. Since there was a small bump, we didn't. And since there was a small bump, and there was a perforation, we didn't want to put any bone, because if you put bone, you run the risk of closing up the ostium, which is not good. So we didn't put any bone. We just placed the collagen plug, placed the implant in. And we told the patient, you might get some bleeding from your nose and things like that, but everything should be fine. Now the patient writes back. No, in fact, the patient tells me that day, say, oh, bleeding from my nose. Okay, oh, wait, by the way, I've always had problems with my sinus. And 2 months ago, I had a sinus, I went to my ENT and they cleaned out my sinus and all that. So I'm still healing from that process. That's after implant has already been placed. Now you come back, you see this. Can you see the sinus on the patient's left side? It is completely full, completely clogged. The patient is complaining of pressure, some pain. They are now using. They are saying they're getting. They started using decongestants, and they started using, there's a netip or something that can kind of clean out your nose. They're getting gunk coming out of the mouth and their nose. And they're saying, oh, what doc was happening? When you look at this, this is not a good day. This is now close to the ugly, the unwanted in implants. You tell the patient, you give them antibiotics, you say, you know what, maybe it's a healing process. Take this, let's wait a few days, continue doing the congestants. Patient calls back after a week or two. The doc, nothing has changed. There's even more gunk. I'm not feeling well. What do? We don't keep the patient on antibiotics. You look at it, you say, you know what, let's step back. Let's just regroup and remove the implant. Take out the cause and see what happens. And that's what we did. We removed the implant and look at, if you see this middle picture here, can you see how much pus was drained from that sinus? This is all pus. This is how we remove. So after the implant was removed, you just put the monojet in the area and just started draining until it was clear. Of course, we kept on flushing the site. And then once it was clear, we flushed the sinus with some saline, drained that as well, and then we closed off that area with, because it's an open site, we closed off with PRF membrane from the patient, and then just continued. Now that was not a good day. First, like I said, I want to explain. First of all, I should have, when you're doing implant surgery, any type of surgery, if it's surgical surgery, always do your homework. Get good medical history of the patient. When a patient tells you that they've done sinus recently, it's best to wait for some time. Don't rush to do anything surgical. And I did not do my good history. I went ahead and first of all did a perforation, which is not good. Perforations are not bad. Those can be mitigated and can be fixed. But I did a perforation, went ahead and placed implants, and then the patient got all this. That was not good. And but after this, the patient was happy. Now, if we had just done a lateral window, instead of doing a vertical, do a lateral, for example. When you do a lateral or sinus augmentation, even if you have a perforation like in this case, this is another case, even if you have a perforation like in this case, you can visualize anything. When you're doing vertical, you can't visualize everything well. It's hard to even close off. In this case, you can just easily put a collagen membrane there. It adapts perfectly to the membrane, to the sinus membrane, and you can still elevate it, pack your bone, and cover it up. But it's because it's a wide site, you can see everything. It's more predictable. And yeah, that's basically it. So I've just gone through a bit of implants, what they are, how they integrate, single implants to surgical. There are many complications. We've just touched like an iceberg of what could be happening. But the most important, I guess the biggest takeaway from what I've just said is always do your wax pattern, know where you want your implant, your crowns to be. Do a CBCT so that you know where you want the ideal placement of your implant is, and then you work forward. If you need to augment the site, augment the site. If you need to wait or not do anything, change the treatment plan. Let the patient know. If you need to, for example, if you do a sinus perforation and you can't, if you need to wait, step back. It's never go. If a patient is pushing you, try and push back and say, you know what, for a better prognosis, I would rather wait so that everything turns out well. So don't be MacGyver. Don't do everything. You can refer it to specialists. We have good specialists in Uganda that can take care of so many things. And even if you don't want to refer, and you want to the case, as in that's why we are on these platforms. Talk to people, say, I have this such and such a case. What can I do? How can I go about, taking care of such and such a thing? And people will walk you through all these things. So that's basically it. That's some of the good, because there's a lot of good, some of the bad, and some of the real ugly out there. And people say, as in, of course, like you said, I'm in the US right now. It's funny sometimes where they give foreigners a hard time, but some of the work that is, as in on the low, some of the work that you still see this side is still wanting. You still get those bad apples everywhere. And yeah, that's it. I don't know if we have any questions, queries, comments.
Okay. Thank you so much, Dr. Kibuuka, for that amazing presentation. I think you've done justice to it. And I know we can only learn from experience. And the
Yeah.
best experience is always first-hand experience. I mean, second-hand, you can read books, you can watch videos, you can see people do these things, but until you
Yes.
knee
Until you've
deep
done it.
into that, the depth of everything, that's when you
Yeah.
know. But I mean, you've talked about the fact that you practice for 5 years, and that's when you see your failures, or else you haven't placed as many. You haven't just done
Yeah.
work, you haven't done as much work for you to be able to
Yeah.
see your failures.
You
Yeah.
won't see unless, because like I said, unless you move, if you move, you won't see your failures. Move
Unless,
countries.
yeah, you can also move countries, move cities or
And
something
you'll
like
have
that. So
100%.
definitely,
Yeah.
definitely. So thank you so much. I mean,
Yeah.
I'm amazed and I'm happy. I think you're the best person who could have done this topic justice. So I don't know if we have any questions for Dr. Kibuuka. I know it's very early in the morning for him and it's late
I'm
for
okay.
us.
I'm awake now.
Not really, but but it's a Friday evening. So if
Mm.
there's any question, please feel free. You can take some on the chat. I'm not seeing any, but in case there's none, I'm still grateful for Dr. Kibuuka. But
Yeah.
in case there's any, please unmute yourself and we can have some discussion around some of the cases that Dr. Kibuuka had asked or had presented. Now, my question was
Yep.
coming in from, maybe I can start us off. Um,
Yeah.
when it came to the case that had the buccal cantilever, and I think this is the biggest problem that we
Yes.
all get. I have bone, and which is, like you said, I don't look at the prosthetics. I don't look at the
Hmm.
final work. What I'm going to look at, I have this thin bone, buccolingual.
Yeah.
I have
Uh-huh.
enough, because on the lower, on the mandible, he actually had space distally and mesial. But then the biggest
Hmm.
problem definitely came from the buccolingual bone. I just like, you
Yeah.
know what? I don't want to do any other work. I don't want to graft, whether in a single sitting with implant placement
Hmm.
or later on. And people just go on and do that. Um,
Yeah.
these cases are what makes or breaks someone. But
Hmm.
how best would you, I mean, according to experience now and what you're doing, would be
Yeah.
the best alternative for someone to handle such a case? Would it be good to do it in a single sitting where you do implant placement and GBR, or would it be better
Hmm.
to do GBR and then implant placement over time? I don't know what your take is on that.
So what I'll say is it all depends on, like I said, where your prosthesis, where you want your prosthesis to be. So let me go back to this case. Let's see. So this one here. I wish I'd shown, because the patient also had on the bilateral side. So in this case, if you see how much thread, if you see like half of the threads are going to be showing in your ideal implant placement, then that one you can step back and say, you know what, I don't want to do implant placement and graft at the same time, because it is almost impossible. It's very difficult, because you can imagine how much you have to stretch your GBR to kind of, there's going to be remodeling, and you already saw the result. Um, after the you didn't get much. If you get replaced implant and the GBR at the same time, you are not. First of all, an implant is going to limit the blood supply and the possible bone you're going to get in that side. That's another thing that you have to consider. So you definitely have to step back and say, when it's like half of the threads of the implant that I plan to put are going to be exposed, GBR first. But if in the shell on the other side, I wish I'd shown it, but on the other side, if you see that it's maybe one thread or two, then there's something called contour grafting, which was coined by Buser, he's European, I think, with the Stroman group, where you can do implant placement and then contour graft at the same time. It's also controversial, because sometimes people say that if you contour graft, you actually always have to put membrane so that the stability of that graft around that implant, so you actually get bone fill. Some people don't put any membrane; they just implant, put bone, and then just close it up. most times you end up just getting soft tissue, which is not bad. If you get soft tissue that is in that covering that area, that's okay. But if it's like a 1 millimeter or 2 millimeters of implant exposed, then maybe you can consider contrast grafting. But if it's more than that, half, like in that case, you step back, you say, you know what, I'm just going to do GBR, wait, and then place implant later. But in a case where, for example, patient doesn't want to go through GBR, there's something wrong and all that stuff, they really want to implant, signed consent is always perfect. We always do them here, and they're very good because, like, we're in the US, it's litigation capital. If you don't do a signed consent, you've not told the patient everything, that's a lawsuit waiting to happen. So you tell the patient, if you are saying you don't want the GBR, you don't want all this thing, then there are other things I can do. For example, you can put 2 smaller diameter implants, but the diameter or the size of the crowns that you're going to put on those small implants is not going to be the ideal size. And so you go back to what Rangat and them said, smaller size, you can put 2 implants, or smaller size, so they have some kind of chewing surface, but it's not going to be ideal. There won't be any food track because it's small, and you won't have done the GPR and everything because it's also. So there's several ways you can go about it. Of course, it's always best to GBR, put the right size, no foot trap. It's ideal, it looks good, and you move forward.
Okay. Thank you so much, Dr. Kibuuka. One final question. Did that patient get implants on both the left and the right?
This one?
Yes.
Yeah. So she didn't get the money. We're still waiting.
Yeah.
So we just checked up on her in June. She's still trying to get the money for. So the plan now is to do now the thing that we said. We did get some bone. It's going to be implant placement and graft because we have some kind of bone. Yeah. So that's what we're waiting for to do. Yeah.
All right.
She'll come back.
Okay. Okay. That's an interesting case. I'd love to see how the follow-up for that is. All right. Anyone with any questions with regards to Dr. Kibuuka's presentation? Okay. I guess sometimes silence means that we are all good. So
guess.
Dr. Kibuuka, I guess that's always a thing. So I'm happy for the time you've spared for us and
thank you so much.
be able to speak to us and give us some knowledge with regards to implants. And always a pleasure to learn something new here and there from a different mouthpiece or something like that. So thank you so much.
Thank you.
For the rest of the people who have attended, I know we have all these marathons of things, but happy that you're here with us, and thank you so much for attending. And we'll definitely be sharing and hearing more from Dr. Kibuuka as he goes on his journey in dentistry. So Dr. Kibuuka, any parting words before I close this off?
No, nothing much. You've said everything. In case of anything, people, as in among the groups, people can always reach out to me and text if they have any questions. But yeah, that's it.
Perfect. All right. Thank you so much. And to everyone else, have a lovely night. Dr. Kibuuka, enjoy the rest of your day.
Yeah, have a good evening that side. Yeah.
All right. Okay. All right. Bye-bye.
Bye.